Good morning, everyone. Welcome to today's presentation. I'm Dr. Asim Hussein, and I'm pleased to have you here. Today, we will be discussing renal papillary necrosis. This is the first slide, which serves as our cover. In this session, I'll introduce the topic briefly and give you an overview of what we'll cover. We'll explore the causes, clinical features, diagnosis, and management of this condition. So, let's get started and dive into the fascinating subject of renal papillary necrosis. All right, let's look at this case. We have a 55-year-old woman who has diabetes and has been using NSAIDs chronically. She presents with hematuria, which is blood in the urine, and acute kidney injury, or AKI. Now, these details are important because they give us clues about the underlying cause. Diabetes is a common risk factor for various kidney issues, especially diabetic nephropathy. But here, combined with her NSAID use, we need to think about other potential problems. Chronic NSAID use can lead to several kidney-related conditions, including decreased blood flow to the kidneys and specific forms of nephritis. The key question is, what is the most likely diagnosis in this scenario? We have several options to consider, such as ATN, AIN, renal papillary necrosis, RPGN, or postrenal obstruction. Each of these has distinct features, but based on her history and presentation, renal papillary necrosis stands out as the most probable. This condition is often associated with diabetes and NSAID use, and it can cause hematuria and AKI. Recognizing these connections helps us identify the right diagnosis and guides appropriate management. So, as we proceed, remember that understanding the patient's history and risk factors is crucial in narrowing down these options. All right, let's take a closer look at the correct answer, which is C. When we talk about postcard risks, we're referring to a variety of conditions that can negatively impact kidney health. These include pyelonephritis, which is a kidney infection, and obstructions in the urinary tract that can cause damage. Sickle cell disease is another important factor because it can lead to sickling of cells in the kidneys, impairing their function. Tuberculosis, or TB, can also affect the kidneys if it spreads beyond the lungs. Cirrhosis, although primarily a liver condition, can have systemic effects that influence kidney health too. Then we have the use of analgesics and NSAIDs, which are common pain relievers, but can cause kidney damage if used excessively or long-term. A history of renal transplant indicates a patient with a complex kidney condition already, making them more vulnerable. Diabetes is a major risk factor because high blood sugar levels can damage the small blood vessels in the kidneys over time. Understanding these risks helps us recognize the importance of monitoring and managing these conditions to protect renal health. It's a key part of the overall theme of preventing kidney disease and ensuring optimal patient care. Now, let's look at the question here. What is the underlying mechanism in papillary necrosis? This is a key point because understanding the pathology helps guide diagnosis and treatment. Looking at the options, the correct answer is C, ischemic necrosis of the renal papillae. This means that the blood supply to the renal papillae is compromised, leading to tissue death. This ischemia can result from various causes, such as vascular diseases, severe infections, or certain analgesic abuse. Essentially, when the blood flow is reduced or interrupted, the tissue can't get the oxygen and nutrients it needs, leading to necrosis. This process is important because it explains the underlying pathology of papillary necrosis, connecting to the overall theme of renal tissue injury. Recognizing ischemia as the key mechanism helps us understand potential risk factors and clinical presentations. The correct answer here is C. Now, to understand why, let's look at what's happening with the kidney tissue. Ischemia of the papillae is a key concept. Essentially, this occurs because the medullary blood supply is particularly vulnerable. The blood flow to this area is relatively limited and quite delicate, making it more susceptible to ischemic injury. When the blood supply is compromised, it can lead to papillary necrosis or other issues affecting kidney function. Recognizing this vulnerability helps us understand some of the pathophysiological processes behind certain renal conditions. So, in summary, The ischemia of the papillae, due to this vulnerable medullary blood supply, is a critical point to remember. All right, let's look at this question. The key here is that the CT urography shows sloughed papillae with filling defects. Now, what does that tell us? Well, sloughed papillae are essentially pieces of the renal papilla that have detached. And when we see filling defects on imaging, it indicates that something is occupying space where it shouldn't be, like these detached tissue pieces. This scenario is most characteristic of papillary necrosis, which is often associated with ischemic injury to the papillae leading to their necrosis and sloughing off. It's important to recognize this because it can be linked to conditions like diabetes, analgesic abuse, or sickle cell disease. So, connecting this to our overall theme, understanding the imaging findings like these helps us pinpoint the diagnosis more accurately. Here, the most consistent diagnosis with sloughed papillae and filling defects on CT urography is option B, papillary necrosis. The correct answer here is B now. Let's talk about why that's the case. Sloughed papillae are actually quite characteristic of papillary necrosis. When the tissue at the tip of the renal papillae dies and sheds, it creates a very distinct appearance. Recognizing these sloughed papillae can really help us identify papillary necrosis specifically. This is important because it ties into the overall theme of understanding different renal pathologies and their distinctive features. So remember, if you see sloughed papillae, think papillary necrosis as a key diagnosis. All right, let's look at this scenario. We have a patient who develops acute colic and anuria following papillary sloughing. Now, papillary sloughing, as you may recall, involves the shedding of the renal papillae, which can obstruct the flow of urine. This sudden obstruction due to sloughed tissue can cause a rapid deterioration in kidney function, leading to anuria, which is the cessation of urine output. Given these clues, the most likely cause here is a postrenal obstruction. This is because the obstruction is located downstream, at the level of the urinary outflow tract, caused by the sloughed papillae blocking the ureter or the renal pelvis. So, when we're thinking about the options, this presentation fits best with postrenal obstruction, which can cause such an acute drop in urine output after an episode like papillary sloughing. It's important to remember that recognizing this pattern helps us quickly identify and manage obstructions to prevent irreversible kidney damage. The correct answer here is D. What this means is that sloughed papillae can actually block the ureters, which leads to postrenal acute kidney injury. This is an important point because it highlights how certain pathological changes in the kidney tissue, like papillary necrosis, can cause a mechanical obstruction. When the papillae slough off, they can physically obstruct urine flow, resulting in a backup and increased pressure in the kidney. That's why understanding these mechanisms is crucial in diagnosing and managing postrenal causes of AKI. It ties into the overall theme of recognizing different types of AKI and their underlying causes. All right, let's look at the key question here. What's the best initial management for renal papillary necrosis? As you see on the slide, we have several options: high-dose steroids, immediate nephrectomy, treating the underlying cause and relieving obstruction, cyclophosphamide, and plasmapheresis. It's important to understand that the primary goal in managing renal papillary necrosis is to address the underlying cause, whether that's an infection, analgesic abuse, or another underlying condition, and to relieve any obstruction if present. Choosing the best initial approach means we want to stabilize the patient and prevent further kidney damage, which makes option C, treat underlying cause and relieve obstruction, the most appropriate choice here. This approach aligns with the overall theme of the presentation, targeting the root cause rather than just the symptoms. So, in summary, the most suitable initial management strategy for renal papillary necrosis is to identify and treat the underlying cause and relieve any obstruction that might be compromising renal function. The correct answer here is C. When managing this condition, supportive care is really the cornerstone, making sure the patient is comfortable and stable. It's also crucial to stop NSAIDs, since they can sometimes worsen the situation. Treating any underlying infection is key, especially if there's an infectious component involved. And if there's an obstruction, urological relief procedures may be necessary to restore proper function. These steps collectively address the immediate problem and help prevent further complications, which ties back to the overall theme of comprehensive patient management. Today, I'll be discussing renal papillary necrosis, starting with an overview and its definition. Renal papillary necrosis is essentially the ischemic necrosis, or tissue death, of the renal papillae. These are the tips of the renal pyramids in the kidney. This condition often results from medullary hypoperfusion, meaning there's reduced blood flow to the medullary region of the kidney. When this happens, it can lead to several significant clinical features. You might notice hematuria, which is blood in the urine, or flank pain, which patients often describe as a dull or sharp ache on the side. Another important point is the sloughing of the papillae. That's when the dead tissue actually detaches and can cause obstruction. This process can also result in obstructive acute kidney injury, or AKI, which is a sudden decline in kidney function. So, to sum up, renal papillary necrosis is a serious condition caused by ischemia, leading to bleeding, pain, tissue sloughing, and potential obstruction. Understanding this helps us connect the dots in diagnosing and managing various causes of kidney injury in our patients. Now, let's look at slide 13. Here, we're highlighting a classic ICU scenario involving NSAIDs and dehydration. When these two factors come together, they can significantly increase the risk of renal complications. We've summarized the common causes of renal injury with the mnemonic postcard. Each letter stands for a different etiology. P stands for pyelonephritis, which is a kidney infection. O is for obstruction, such as stones or tumors blocking the urinary tract. S represents sickle cell disease or trait, which can lead to vaso-occlusion and kidney damage. T is for tuberculosis, which can involve the kidneys directly. C is cirrhosis, often associated with changes in blood flow and kidney function. A stands for analgesic use, specifically NSAIDs, which can impair renal perfusion, especially in dehydrated states. R is for renal transplant, highlighting the risk of injury to transplanted kidneys. D is for diabetes mellitus, a major risk factor for diabetic nephropathy. This mnemonic helps us quickly recall these key causes. And importantly, it ties into the overall theme of renal injury pathways and how multiple factors can converge, especially in vulnerable patient populations. Finally, we should note that renal papillary necrosis is a potential outcome, often linked to these causes, especially when NSAIDs and dehydration are involved. It's a form of ischemic injury to the renal papillae, leading to possible hematuria and renal impairment. So, understanding this postcard, mnemonic, and its components is vital for recognizing risk factors and preventing renal injury in critical care settings. Let's talk about the pathophysiology behind renal papillary necrosis. The renal papillae, which are the tips of the renal pyramids, are supplied by tiny blood vessels called vasa recta. Because of their specific blood supply, these areas are highly vulnerable to ischemia, or reduced blood flow. Now, when NSAIDs are used, they inhibit the production of prostaglandins, which are important for maintaining adequate blood flow to the kidneys. This decrease in prostaglandins causes afferent vasoconstriction, meaning the blood vessels leading into the glomeruli constrict, reducing blood supply further. This compromised blood flow can lead to tissue damage or necrosis at the papillae. When this tissue sloughs off, it can cause an obstruction in the ureter, which is the tube that carries urine from the kidney to the bladder. This process results in what we call renal papillary necrosis. Recognizing this mechanism is key because it links the use of certain medications like NSAIDs to specific renal complications, emphasizing the importance of understanding both the anatomy and the pharmacology involved in kidney health. Let's take a closer look at renal papillary necrosis and its clinical features. Anuria, or the absence of urine, can occur when there is an obstructing sloughed papilla blocking the flow. This is a key point to remember because it highlights how tissue necrosis can directly impact kidney function. Clinically, patients may present with gross or microscopic hematuria, meaning you'll see blood either visibly in the urine or only detectable under a microscope. Flank pain is also common, often due to the necrosis or any associated inflammation. If the cause is infective, fever may be present, signaling an infectious process alongside tissue necrosis. Another important feature is the sudden onset of acute kidney injury, or AKI, which makes sense because the kidney suddenly can't filter properly when these papillary tissues are damaged or obstructed. Additionally, patients might notice the passage of tissue fragments in their urine, which is a hallmark of sloughed papillae. Recognizing these features is crucial because they help us identify renal papillary necrosis early and differentiate it from other causes of AKI. Overall, understanding these clinical signs helps us connect the pathology to the patient's symptoms and guides appropriate management. Let's now move on to diagnosis, which is crucial for identifying renal papillary necrosis. The gold standard for imaging is CT urography, as it provides detailed visualization of the urinary tract. On the scans, you might see filling defects, which are areas where the contrast doesn't fill the calyces or pelvis properly, indicating possible tissue damage or sloughed papillae. Another key feature to look for is the ball-on T sign, which refers to the appearance of sloughed papillae sitting within the calyces, resembling a ball resting on a T. Additionally, cavitation of the papillae, that is, the formation of cavities within the papillae, is another hallmark seen on imaging. Moving on to labs, patients with renal papillary necrosis often present with hematuria, which is blood in the urine, and sterile pyuria, meaning white blood cells in the urine without bacteria, indicating inflammation rather than infection. Worsening renal function is also a common sign, as the necrosis impairs kidney filtration. In summary, recognizing these imaging signs combined with lab findings can help us accurately diagnose renal papillary necrosis and guide appropriate management. Let's now discuss some of the common complications associated with urinary tract issues. One major complication is obstructive uropathy, which occurs when there's an obstruction in the urinary tract, leading to impaired urine flow. This can cause significant damage to the kidneys if not addressed promptly. Sepsis is another serious concern, especially when infections spread from the urinary tract into the bloodstream, posing a life-threatening risk. Chronic kidney disease can also develop over time due to persistent infections or obstruction, gradually impairing renal function. Recurrent urinary tract infections, or UTIs, are not only uncomfortable, but can also contribute to these more severe complications if they happen repeatedly. Lastly, I want to highlight renal papillary necrosis, a condition where the tissue in the renal papillae dies, often due to ischemia or infection, and can lead to hematuria and impaired kidney function. Understanding these complications underscores the importance of early diagnosis and management in maintaining renal health and preventing long-term damage. Let's talk about management strategies for renal papillary necrosis. First, it's crucial to treat the underlying cause of the condition. Identifying and addressing the root issue can prevent further damage. If nephrotoxins like NSAIDs are involved, stopping these agents immediately is essential to reduce ongoing injury. Aggressive hydration also plays a key role. Ensuring adequate fluid intake helps maintain renal perfusion and can support recovery. If there's an infection, administering antibiotics is necessary to control the infectious process and prevent further renal compromise. In cases where there's an obstruction, urological intervention may be required to relieve it and restore normal urine flow. And for severe acute kidney injury, dialysis might become necessary to manage the patient's fluid and waste balance effectively. Overall, managing renal papillary necrosis involves a combination of addressing causes, preventing further injury, and supporting kidney function until recovery. Let's talk about the prognosis for renal papillary necrosis. The key point here is that the prognosis can vary significantly depending on the situation. If the condition is caught early, it can often be reversible, which is encouraging. However, if the disease progresses to involve both kidneys or if sepsis develops, the outlook becomes much poorer. This highlights the importance of early detection and intervention. Remember, the severity and extent of the disease really influence the overall prognosis. So, understanding these factors helps us better predict outcomes and tailor our management strategies accordingly. Now, let's discuss MRCP-PARLS specifically related to papillary necrosis. When you see a patient with a history of NSAID use, diabetes, and hematuria, think about the possibility of papillary necrosis. These factors are key contributors because NSAIDs can impair the blood flow to the renal papillae, and diabetes predisposes to microvascular damage, making this condition more likely. If the patient suddenly develops anuria, it's often due to an obstructing papilla, which blocks urine flow completely. In such cases, a CT urography is the diagnostic tool of choice because it provides detailed imaging of the renal collecting system and can identify the location and cause of the obstruction. Another important point is that sickle cell trait alone can be enough to cause papillary necrosis. The sickled cells can occlude the small vessels in the papillae, leading to ischemia and necrosis. It's also worth noting that papillary necrosis can mimic renal colic, so clinical suspicion is crucial. The presentation can be similar, with flank pain and hematuria, but the underlying pathology is different. To sum up, always keep in mind these risk factors and diagnostic clues, as recognizing papillary necrosis can significantly impact patient management. Thank you so much for your time and attention today. I really appreciate you being here and engaging with the material. As we wrap up, I want to emphasize that the key points we've discussed highlight the importance of understanding the core concepts and applying them effectively. Remember, the overall theme was about growth and innovation, and I hope you leave feeling inspired to take these ideas forward. If you have any questions or want to explore these topics further, please don't hesitate to reach out. Once again, thank you for your participation and interest.